Okay, so I apologize about missing class on Wednesday. It was our first real course, and we didn't hit the mark. So I am going to present this lecture for you specifically, and I'm going to do a lot of drawing for you. As you can see here, I've got my pen kind of ready to go here, and I'm going to walk through this very slowly with you simply because this is probably the most important lecture of the semester, and it's the foundation in which we're going to build everything upon as we move further into this content. So we're looking at the basics of pharmacology, and these basics are going to be focusing around something called pharmacokinetics and pharmacodynamics. And before we get into those concepts and I start drawing for you, I just want to refresh your memory that we will be kind of going back and forth between these different focal points, right? So as of now, we're going to be talking about just the physiology of things, how we can go from physiology to a pathophysiology state or a pathogenic state, and then how these two things, both pharmaceutical therapy and exercise, can bring us back to this condition. However, sometimes these two things don't get along, and that's kind of what we're going to focus on as we move forward. I had told Robert that moving forward, I'm going to let you guys have a choice in how you want to interpret this information. So we can look at this class moving forward as a way of looking at athletes. I'm just going to put a big A here for athletes. And there might be a small population of athletes that are on some type of pharmacotherapy, some type of drug for some sort of issue that they're dealing with. I have not come across many of them. However, if you are an elite athlete and you are dealing with some type of ailment and you are relying on some type of pharmaceutical therapy, how might that be impacting both normal physiology and your ability to perform and exercise physiology? So you can kind of go that route. You can look at this course from the lens of an athlete and say, yeah, I kind of want to see like how this works in people who are in really good shape. Or what we can do, and I kind of have a feeling you're going to be interested in this, is we can look at people who are dealing with pathologies, the variety of pathologies that are out there, who are using drugs to try to get back to a normal physiology. However, when we are dealing with clinical issues and we're dealing with individuals who are receiving this type of treatment, we do prescribe exercise. And we hope that both these pharmacogenic aids and exercise together can kind of accelerate their healing process or getting back to physiology. However, some people that are on certain type of drugs, they're going to have complications with exercising, and exercising might alter the drug. So I'm going to let you kind of choose how you want to look at this class going forward, because when you guys do presentations for me, you can do it in a clinical population. For example, people who are taking carcinogenic drugs to help them with cancer, or diabetic drugs, or hypertensive drugs. And you can see how exercise might essentially interfere with the mechanism of action for those drugs. But that's entirely up to you. So let's move forward. I just want to kind of remind you that these systems are all kind of intertwined here, and that is the most important thing that I want to take away from this course. So when we're talking about what is pharmacology, basically, it is this science of how drugs and medications interact with a biological system. Now, I want to take some time and talk about this biological system because I don't think the textbook does a really good job of explaining how diverse and how complicated a biological system can be. So I pose a question for you. I say, okay, well, what system are we talking about here? When we're talking about a drug's action, we have to think about a biological system as a variety of possible things. So from one, are we talking about a healthy biological system? Are we talking about a compromised biological system? Are we talking about someone who is in recovery from some type of issue, some types of complications, some types of illness? Are we talking about the entire human body as a system? Or if we take some type of medication, right? We take this kind of pill right here, that's a pill, and we ingest that pill. Let's say that pill it's a pill meant for cardiomyocytes, and it's meant to help with heart rate or strengthening the heart. Well, then we're talking about a biological system that is focusing on the heart. Are we talking about a biological system that is focusing on the liver? Because the liver is its own biological system. It is the only system in the body that is composed of hepatocytes and liver cells. So hepatocytes and liver cells have a very different function than cardiomyocytes. Are we talking about kidney medication? So when the textbook talks about a biological system, it doesn't really clarify how complex a biological system can be. And the first thing that we have to do is we have to say, okay, well, what or whom are we talking about? Because when we're talking about these pharmacological aids, we have to zoom in like a microscope. Well, yes, we are talking about the human body. We're talking about how this medication works with the human body. But where is that medication going to go once it's ingested? Well, it's going to have to go to the stomach first, okay? Well, the stomach is its own biological system. So what is the stomach going to do to that drug? And then that drug has to get into the bloodstream. Where is it going to go then? Well, maybe it's going to the liver, or maybe it's going to the heart, or maybe it's going to the kidney, to its primary mechanism, to do its primary therapeutic effect. Well, then we got to kind of zoom in, right? I said we have to look at this like it's a microscope. So if we look at the whole body, that's one magnification. If we zoom into a specific organ, let's say we zoom in 100 times, right? That's another magnification. Let's say then we have to talk about specific cells in that organ or in the body. That would be another magnification. So I'll say we take that magnification, we go in 200 times, and then that drug is going to act a certain way inside of, no, that's a bad color, let me get a different color. The drug is going to act a certain way inside of that cell. So it's going to have a mechanism of action in that cell. So when we talk about this biological system, I'm asking you to think about, well, what system are we referring to? Are we talking about a systemic system? Are we talking about a cellular system? Are we talking about a specific organ? And like I said, the textbook really doesn't do a good job of talking about that. So I want to make sure that we put on the right set of glasses, or we put on the right lenses when we're reading these papers, or we're talking about these specific mechanisms of action of drugs and where they're working and how they're working. Okay, so let me give you a quick example about how a simple supplement like potassium here, because a lot of these companies tell us that we need these exogenous micronutrients to help keep us healthy. But let's talk about how something as simple as taking potassium supplements changes in different biological systems. So if we have a healthy system, right, just normal physiology, somebody who is very healthy, we know that potassium plays a very, very important role in basically increasing the cellular fluid. I'm just going to draw these lines here like this. Increasing the cellular fluid inside of our cells, right? That's a great thing. That's where the organelles float around, and that's where we have reactions happen. When we have a loss of cellular fluid, that is problematic because then the cells don't function right. So if somebody is not getting enough potassium in their diet and they need to go to supplements, well, then they're going to aid in cellular fluid. This here says nerve health, right? It says that this helps with neurological reactions and so forth. Well, when we have the same supplement, but we're in a compromised system, so let's say we're talking about with somebody with diabetes. Well, one of the first impacts or one of the first hits that happens in diabetic injury is we have a loss or a decrease in kidney function. When we have a loss or a decrease in kidney function, which normally removes potassium from the body, we store an excessive amount of potassium. So, most people don't know what potassium does. Most people don't know how much they need throughout the day. What is a healthy dose? So if you have a diabetic who's taking extra potassium and they're taking 99 milligrams twice a day, well, that's going to be problematic, because then they are going to have high potassium and they're not going to be able to get rid of that potassium through the normal kidney excretion and urine excretion. So they are more likely to have complications because of taking these potassium supplements. So if we're talking about an athlete now, well, if we're talking about somebody who's exercising quite a bit and they're sweating quite a bit, well, we know that most of our sweat, right? So I'm going to draw this right here. This is one of my arterioles, right? My blood is going through the arterioles, right? Well, when we sweat, we know that most of our sweat comes from the blood, right? It comes from the fluid in the blood, or more specifically, the water that is in the blood. And if we continue to sweat and the blood volume goes down and the blood becomes more viscous, right, it becomes a little thicker, and the thickness of that blood increases, well, then the body is going to start removing water from the interstitial space, right? And where the interstitial space is that's all the liquid that surrounds our cells, right? So if we have cells here, cells here, cells here, cells here, cells here, this interstitial space is all fluid and water. So if we begin to become too dehydrated and we remove most of the liquid from our blood, well, then we'll start pulling liquid from the interstitial space. And then once that is gone, we will start pulling water from the cells themselves. And then that water will leave, enter the interstitial space, and then enter the bloodstream, and we will sweat it out. So somebody that is an athlete, well, it might be a really good idea for them to take potassium, because it will help with the rehydration process after the exercise. It'll help get that fluid back into the cell quicker, right? But this is a very benign supplement, but just showing you how that supplement in different biological systems will have different ramifications. So we need to be very aware of that. So moving forward, now that we have these glasses on, right? I just showed you, like, we have to be very aware of what biological system we're talking about. We are going to focus on the action and the mechanisms of drugs. Today, we're going to get into the pharmacokinetics and the pharmacodynamics. We will be talking a bit about therapeutic applications. We won't get too far into that yet. We will be talking about the adverse effects of drugs, and most importantly, how are these things working with exercise. And let me go on to the next slide here. So, this part I kind of already explained. You can look at this slide and read it on your own. But the question I want to pose to you is, for the rest of the semester, do you want to look at this course through the lens of how drugs might negatively impact exercise? So for someone like a clinical population, or do we want to talk about how exercise from a healthy individual might impact a drug's mechanism of action, right? We're trying to figure out this relationship between these two here. And then, as I said here, I will let you choose how you want to proceed moving forward. Okay, so now we're going to get into the meat and the potatoes of this lecture, and we're going to be talking about kinetics and dynamics. And a real easy way to memorize this is when we're talking about pharmacokinetics, we are talking about what is the body doing to the drug. Okay, so we take a drug. Oops, sorry about that. Let me go back. We take a drug. Okay, the drug enters the body. Now, what does the body do with it? That is the kinetics. Okay, and then when we start talking about the dynamics, then we start talking about once the drug gets where it needs to be, right? Let's say we're taking a drug for cholesterol, right? And that primary action is going to happen here in the liver. Well, once the drug gets where it needs to go, right? That's the kinetics. And then that drug gets to the liver, well, then what does the drug do to the body, or what will it do to the liver? That's the dynamics. So we have kinetics, where the body is imposing itself on the drug, and then we have the dynamics, where the drug is imposing itself on the cell in the body. So we're going to just really kind of talk about kinetics today. So when we're talking about kinetics, right, we're talking about this ADAM, and what this stands for is absorption, distribution, metabolism, and excretion. And Robert and I during class, we only got through absorption and a little bit of distribution, so you didn't miss much of the class. So we're going to talk about how once the drug is ingested, or once the drug is taken into the body, how does it get distributed? And we have multiple means of absorption, and we have a couple means of distribution. We're not going to do much with metabolism yet, so that's really what we're going to focus on here. And basically, we have several ways of absorbing a drug. Okay, and on this next slide here, we talk about that. So we can take a drug, we can actually put a drug under a tongue, and it can get absorbed. We can take a drug orally, which is the most common, right? We can take a drug through some sort of inhaler, where we can get it into the lungs and get it into the bloodstream there, right? We can do transdermal, which would be like an ointment where the skin absorbs it. We can put a drug into the eye, into the nose, right? Under the mouth or under the tongue. We can go anally or vaginally. So we have all these different ways of getting the drug to where it needs to go. And ultimately, what we're trying to do is get that drug to be distributed through the body, and we want to get that drug into the blood, right? So all of these methods here are all going to initially get the drug into the bloodstream, so then the blood can be distributed. Now, each one of these ways of administering a drug, they all have different rationales for being administered. For example, some drugs do not do well once they hit the stomach, because the stomach acid will destroy the drug. It will chew it up and completely destroy it. And then if we have a drug that is destroyed, well, then it won't have any therapeutic action whatsoever. So for example, a lot of penicillins, or drugs that we use for STIs or STDs, right? That those bacteria and those viruses are so resistant to our antibiotics that they really need to be given through a syringe, right? So those types of drugs we would give directly into the skin or the muscle via a syringe or a needle, right? And the reason being is because when we use that type of delivery method, well, that bypasses the stomach, right? And if we bypass the stomach, we won't lose any concentration of that drug. And what I mean by that is, if I give you, let's say, 200 milligrams of some drug, right, and we ingest it, and once it gets into the stomach, well, then the stomach acids and the acidity in the stomach is going to chew some of that drug up, right? Which means by the time that drug leaves the stomach, we might now only have 150 milligrams of that drug, because we lost some of the concentration in the stomach. And drug designers know that, which is why they have to give you a prescription based upon your size and your weight. And they have to keep in mind that if you take a drug orally, which we're going to kind of talk about today, if you take a drug orally, by the time that drug leaves or gets into your mouth, there's teeth, right? There's some eyeballs. I'm not a great artist. There's the nose. By the time the drug gets into your mouth and gets to the cells that it needs to get to, we might lose 75% of that drug's concentration. Because what does that drug have to do? Well, if we look at the human body, it is... Oops, sorry about that. If we look at the human body, oh my gosh, sorry, I'm left-handed, so I'm touching the side of the tablet here. If we look at this, the human body, it is just filled with barriers, right? And those barriers are the cell membranes, the different organs, right? The intestines, the small intestines, the hepatic portal vein, the liver itself, right? And those barriers, every time a drug has to enter or get past a different type of barrier, it's going to lose some of its concentration. So doctors, when they're prescribing you some type of drug, they have to say, okay, well, what is the therapeutic, I'm just going to put TA, what is the therapeutic amount that I need to get into their body to get rid of this ailment, right? And what I mean by therapeutic, and this, we're going to kind of talk about this in a little bit when we talk about bioavailability, is, but let me introduce it to you now. When we have a drug, I'm just going to put Y and X. This will be time. This will be drug action. We want that drug, so let's say blue is just drug A. Okay. When drug A enters the body, it's got to go through a bunch of barriers, right? And the drug is going to do something like this. It has a half-life. And eventually, over time, it's going to go back down, right? So when we design a drug and when we prescribe a drug, we know that if the drug stays under this line, then that concentration, that concentration was too weak. Oh my goodness. Too weak. Okay. And if a drug, let me change the color here. If a drug is, let's do orange. Or let's do white. Here we go. And then if we have a drug that goes above this line, then that is too much of the drug, and that could be toxic, right? So if that same drug, that drug A, we put it into the body and it goes here, well, now that drug can be very toxic to the body for a pretty long period of time, right? So you see that, how the curve is up over that toxicity level. So when we prescribe a drug, we want to make sure that we understand how the drug is going to be absorbed, distributed, metabolized, and excreted, how long it's going to be in the body, and we want it to be within this therapeutic range so that whatever you are fighting, we can get rid of with the drug that we're delivering. That is the therapeutic range, right? So we have to decide how we're going to deliver the drug, and we want to make sure that it's not too weak, right? Which would be here, and it's not too strong, but it's just like the Goldilocks and the Three Bears, right? It's just right. We give it the right concentration to have the right therapeutic effect, which is why they say don't take other people's prescribed medications. Okay, let's move on. Okay, so let's get into some of the meat and potatoes now and talk about how absorption works. And we're going to focus primarily on a drug that is going to be ingested orally. Like I said, there's many different ways to kind of get the drug inside of the body, and ultimately we're trying to get we're trying to get the drug to the bloodstream, right? So we can let me move this out of the way here. Let me get it on that side. There we go. We can adjust a drug and we can put it into the stomach. And then the stomach will break some of that drug down, right? Again, if we had, I'm just using arbitrary numbers here. We had 2 milligrams of a drug. It goes into the stomach. It leaves the stomach. We might have 150 milligrams left, right? We lose some of it. Every barrier that it has to go through, we lose a bit of it. We could also enter a drug via a suppository in the anus, right? And that drug would have to travel up through the anus into the small intestines, right? And interestingly, both the drug that is being delivered orally wants to get to the small intestines as well as if we had a suppository and we wanted that to get into the body, we'd want that to get into the small intestines also, where the drug can be absorbed and taken to the hepatic portal vein, and we'll talk about that in a moment. We also could use a drug, let's just say this is an ointment, right? I can put this ointment on the skin, and then that ointment could move through the skin, be absorbed through the dermis, right, and into the blood this way, right? Or we could easily just take a syringe, right? If we had an insulin needle, right, which you've probably seen 1,000 times, right, and it has this. Well, let me be true to form here. An insulin needle is usually orange, right? It has the orange on it, so we know it from the orange cap. And this, and we can put that needle through the dermis into the blood directly. Now, what would be different about this approach is if we did it that way, if we had 200 milligrams of a drug and we put it through the skin directly into the blood, well, once it got into the blood, we would have 200 milligrams. Now, that's great if we need a high dose of that for the therapeutic effect. But if we don't need a high dose of it, then we can get into toxicity. So think about that last slide that I showed you, right? And this has to be calculated. We have to think about these things. We could also use a drug. We can do an inhaler, right? This is the inhaler. There's that little thing there. We could spray a drug into the lungs, and we could get the drug in that way because we know that the alveoli that are surrounded by the lungs, right? We know those little pouches where we fill the air sac with, we bring in O2 and then we release CO2. We know that that area is highly vascularized with capillaries and also capillaries for deoxygenated blood, right? So we know we could deliver the blood that way. Now, ultimately, these methods of delivery or of absorption have one primary goal, and that primary goal, as I said before, is to get that drug into the bloodstream, right? And now we have our red blood cells, and now the drug, I'm just making it look like a pill, is in the bloodstream, okay? And it's going to go to its target tissue, right? So this would be a target. And that target tissue could be whatever, right? We don't know exactly what that target tissue is. It's drug specific. So now let's talk a little bit about these mechanisms of absorption, okay? So like I said, we want to get the drug into the small intestine, especially if we're talking about an oral drug or if we're talking about a suppository that has to go up into the small intestines from the anus or down into the small intestines from an orally consumed drug. And this is where we are going to have most of the absorption conducted within this large surface area of the small intestines. Now, why is the small intestines so wonderfully equipped to do this? Because if we looked inside of the small intestines, we would see that they have this wonderful thing. You probably heard of this before, but it's probably been a while, called villi, right? Which are these like finger-like projections that protrude upward towards the lumen of the small intestines, and it happens on both sides, right? We get it over here as well, right? And what does that villi or vila, people pronounce it differently, what does it do? Well, it increases the surface area of the small intestines so that we can better absorb things, right? And these finger-like projections that are reaching towards the lumen, right? They're all reaching towards the lumen. We call this the villi or the villa, right? And you probably heard about that before. And the villi or the villa, these are highly vascularized as well. So we have lots of capillaries underneath them, right? Lots of capillaries, right? So that's the capillary, those are capillaries, right? And then we have lots of deoxygenated capillaries, right? And what do these things do? Well, the villi will take a drug. So if the drug is coming down the pipe, and it will basically allow absorption to happen here, and that drug can now get into those capillaries. That's why we have that vascularization there. And where is it going to go? Well, the first place it's going to go is to the liver, because the liver is the primary site for all metabolism that happens in the body. And it's going to go to the liver via something called, I'm just going to draw a blood vessel here. You see that blood vessel? I'll make it look like it's a vessel. And we call this the hepatic portal vein. And that's where the drug is going to be absorbed into the small intestines, and it's going to ultimately make its way to the liver. And there we have something called first pass or first phase metabolism. So ultimately, the liver is now going to take a fraction of that drug, and it's going to distribute it to the rest of the body, right? So if we had 200 milligrams when we took it in, once it left the stomach, we were left with 150 milligrams, and then it had to go through all these barriers here and get into the vein and then get through the barrier here, right? Because we know the liver has a membrane. Well, once it gets to the liver, we might have 110 milligrams, and that's how it works when we ingest these drugs and they have to pass these intense barriers, right? So I want to focus a bit more on this absorption piece, because there is not a one-size-fits-all for drug absorption. And let me just kind of clean this up a little bit, okay? So here we have the villi or the villa, and I drew it just like this, right? So this would be those finger-like projections that are reaching towards the lumen of the small intestines, and then we have them coming from the top as well, right? You've seen this before, okay? And this would be the lumen. And we know that the lumen is just the center, right, where things can pass through, right? So here's more of those finger-like projections coming from the top. And the drug is in the lumen of the small intestines, and it's going to be absorbed into these villi or villa, right? This is where the magic happens. So the drug has to be taken into the body via these finger-like projections. So let me zoom in on those finger-like projections so that you can see that a little better. Okay, and I'm going to continue to draw over here. Let me just clean a little bit of stuff up for you. Okay, let me get rid of this because that's just not helping us much at all. Okay, so we have the villa or the villi, right? And it looks like this. Finger-like projections, right? And here is just one of those finger-like projections. So I'm just kind of zooming in on one, okay? And what you should be able to notice right away is that these finger-like projections are made of these certain types of cells called introcytes right here. Introcytes, right? So here's a cell, right? Here's the nucleus, here's the nucleus, here's the nucleus, here's the nucleus. And the villi, it goes like this, right? Up and down, up and down. And that's what I'm showing you here is just kind of one of those finger-like projections that are reaching up towards the lumen, right? The drug is right here. It's floating through the lumen. Well, the drug has to get past this barrier, right? And if it gets past this barrier, as you can see, here is more of that capillary, and this blood supply right here will help get that drug into the hepatic portal vein and get it to the liver, right? So obviously we can see that these capillaries here are oxygenated blood, and then we can see here we got deoxygenated blood, right? Each villa is highly vascularized, right? So if we kind of zoom out and we look at, let me clean this up, we look at a couple of these villi. I know I keep saying it differently. It's just been embedded in my head that way to hear it differently. So here's one and here's two, right? Each one of those has a lot of capillaries, right? So capillaries follow it, capillaries follow it, right? We have all these capillaries down here. We have also the capillaries for deoxygenated blood, right? So these villi, they're filled with these capillaries, and that's what I'm showing you here. Well, so we have a problem here. How does this drug, or what's left of this drug, how does it get through these introcytes, these cells, right? And I'm going to draw it over here. These cells make up the villi, right? So they're all kind of on top of the villi like that. So you see how those cells are kind of populating these finger-like projections. Well, that's what I'm talking about right here. So there's a couple different ways these drugs can get past this barrier. And then if you look here, I have these like little hair finger-like projections here. And each one of these introcytes have something on top of them called microvilli, right? And that's what I'm drawing on top of it. It looks like little hairs. And these just kind of help reach towards the lumen and capture things that we want to use for absorption. Okay, so each one of these introcytes on the villi have microvilli as well. And I'm just kind of drawing them like this. Okay, so if I zoomed in over here, you would see the little microvilli popping out, right? That's kind of what that's doing, right? That little microvilli, right? All right, so let me zoom back out here. All right. And this is, let me clean this up because that looks awful. I'm left-handed and it's just really hard to write on the tablet. V-I-L-L-I. And then this would, of course, be the micro V-I-L-L-I. Okay. So we know that each one of these cells are held together by something called tight junctions, right? So we have this space in between these cells, right? And for people that have irritable bowel syndrome or leaky gut syndrome or inflammatory bowel syndrome, these tight gaps between these cells become compromised, and that's why they have chronic inflammation, because then what happens is those cells start to go like this, and they have a lot of space between one another. And what happens when you have a lot of space between one another, the food that you ate in big chunks that haven't been digested can easily get through those spaces and cause a lot of inflammation here within the interstitial part of the villi. So when we deliver drugs, we have to count on the fact that there are no complications with their intestinal lining, and they don't have any inflammatory bowel disorders, and the drug can potentially make its way through these really tight gaps here, right? So that's the first one we're going to talk about. So I'm going to zoom out. We understand that the villi that lines the inside of the small intestines are populated with these introcyte cells. We know these introcyte cells contain microvilli on top of them, and we know that a drug has to somehow get past this barrier, right, to get into the blood. So we can either go in between these barriers, which I showed you in the blue, okay, or we can go through these barriers like this. But if we go through those barriers, we got to rely on some different type of machinery. All right, so let's talk about some different ways that these drugs can be absorbed. And we're going to talk about two very opposite versions first. All right, so what I have here in red is the small intestines. All right, so that would be the membrane. Okay, and what I'll do to help you out here is I'll just kind of draw those introcytes, right? There they are. There they are, right? There they are. Here's the nucleus of those cells. Here's the microvilli, right? And so that should be familiar to you, right? So the first one that we're going to talk about is just a small drug, right? So we have a small drug. And if you think about a small drug, think about something like an Advil, right? It's a very small tablet, right? It has small molecules in it. I'm just giving you Advil as just a way to say, oh yeah, there's small and large drugs, right? Where if you take like a 1-a-day vitamin, that thing's like a horse pill, right? It's just gigantic, which means it needs more breaking down. So if I have a small drug, And that drug has hydrophobic properties, which means it does not like water, right? So there's a water droplet. It's hydrophobic. It doesn't want anything to do with water. And this drug moves from a concentration that is from high to low, like mostly we see in passive diffusion. Well, that drug can then make its way through, let me just kind of clear this out, through these tight junctions here, right? So if we have this cell, so let me go back to this. If we have this cell membrane here, I'm just really kind of zooming in this cell membrane here, and then we have these tight junctions right here that are holding those cells together and holding those cells in place, right? That's what that is there. These small drugs, if it's moving from a high concentration, so let me draw more of its buddies around it, right? This is all part of that drug. And down here's low concentration. We can passively diffuse through those intracytes and then get that drug into the blood, right? And I'm just going to draw a blood vessel here, right? And we know that that's a capillary because I drew it before, right? And inside of that is red blood cells, right? So now that drug can get inside of the blood cells and make its way to the liver, right? So that would be a small drug that's hydrophobic, doesn't like water, and it moves from a concentration of high to low. That would be one example. Another example would be something completely opposite. So this would be, let me rewrite this. This would be, just so it's a bit clearer for you, this would be a very large drug, right? And we're not really we don't care too much about like the names or what types of drugs. I just want you to understand the property of these drugs. So this would be a large drug, right? And this is a large drug that will basically need a receptor. So this is a very different type of movement from after we ingest a drug. So let me again draw those intracytes for you, and I'm just repeating that over and over again so you can keep hearing the words, right? So here would be one of the intracytes with a receptor on it. Okay, here is that, here is that. Here's another intracyte here, right? And we know that like all cells in the body, they are, here's the microvilli, right? Here's the microvilli. We know that all cells are populated with different types of receptors, right? Well, when they design a drug that is very large and requires something called bulk movement, well, this type of drug requires endocytosis. So what happens is a very large drug will have properties on it that will recognize certain receptors, right? So if we design this drug, we have to understand intracyte physiology. And what will happen is once that drug binds to that receptor, it will mobilize, let me zoom in here, it will mobilize these vesicles, right? And this vesicle will come up to the membrane. It will open its mouth like Pac-Man, right? And it will allow the drug to enter that vesicle. That vesicle will encapsulate it. It will swallow it. And then the drug will be inside of this vesicle. And then that vesicle will move to the other side of that cell. It will create like a Pac-Man sort of looking thing again, like this. Okay, so we have, that's a poor man's Pac-Man. And it will spit that drug out the other side. And we call that endocytosis, right? So if we have a very large drug that needs a receptor, we will undergo a process of endocytosis where the drug will bind to the receptor. That receptor will then signal to the cell to mobilize a vesicle. I'll just put V for vesicle. That vesicle will move to the membrane. It will embed itself in that membrane. It will take the drug into the vesicle, like you see it here, and then it will move that vesicle to the other side of the membrane and spit it out so that that drug, or what's left of it, can get into the bloodstream and move towards the liver, right? So that was like really, really large drugs, okay? So far we have passive diffusion, right, with these small drugs that require certain conditions, hydrophobic It has to be a hydrophobic drug, and it has to be a concentration that moves from high to low. When we get over here to these like really large drugs, it's called bulk movement. And this needs a receptor and will undergo endocytosis, and that's what will get that drug into the bloodstream. Okay, so I have two more very similar ones now. Okay, so now the third way of getting into the blood, so again, here's the membrane for the small intestines. This is the villi, right? Here are those introcytes. There's the nuclei. Here's the microvilli, right? And like I said before, a lot of these will have receptors on them. So there's a receptor, microvilli, right? Receptor, okay? So we know how all this works now, okay? So I'm going to use this one as my example for the next one, okay? So much like the receptor that I showed you on the previous one, some of these introcytes will have protein transporters. So I'm going to put this one right here and then put this one right here. Okay, and then I'll put the same thing down here and I'll put the same thing down here. And what these are protein transporters. Okay, so we have a drug that is too big to fit between these tight junctions, right? It tries to go in, it gets spat out. We have a drug that is not recognized by a receptor, right? This drug tries to bind to a receptor, it's rejected, right? So if we have a drug that is hydrophilic, and which means, I'm going to rewrite that because it looks like I just kidnapped somebody with this handwriting, like it's a ransom letter. This is, let me fix this for you. This is hydrophilic. That means this thing likes water. Okay, this drug likes to be surrounded by water, so it needs a different mechanism to move it, right? So this thing, it says, yay, water, right? That's what hydrophilic means. This type of drug that is a large drug, it can't fit through the tight junctions, it can't be recognized by a receptor, but it is hydrophilic. That allows it to use these protein transporters, right? So here's the nuclei, here's the microvilli, here's a receptor. Okay, so what happens is this drug, let me keep the same color for consistency. This drug will interact with the introcyte, and these protein transporters will move it through the introcyte to a next set of protein transporters that will recognize it and spit the drug out. And then that drug can now get into the vascular system and make its way to the liver, right? Now, the thing with the protein transporters is that the drug and its movement is facilitated, which means it's helped by these protein transporters. All right, I'm going to give you one more here, and that should be enough for you to digest, pun intended, for the next few days. So let me just kind of draw this out one more time. So there's one more kind of way we can get drugs into the body, and here again is our usual suspects, right? We have our introcytes, they're embedded in the small intestines, we have the nuclei for those cells, we have these make up the villi, right? And then here we have the microvilli on top. We know that there's receptors. Now we also know that there's protein transporters embedded in there, right, that can help move a drug. Let's put some here, let's put some here, let's put some here. We know that we have these kind of vesicles waiting inside of the cells to help with endocytosis and to move those drugs here, to exocytosis, to spit those drugs out there, right? So what's remarkable about the pharmacists and the PhDs that design this stuff is they have to figure out how to hijack the cell to move these chemicals through the cell. So it's just wonderful science. So inside of, and I made this one a little bigger, inside of this intro site, right, here's another one. I have this big green thing, right, and I purposely made it large, right? Oh, and I forgot another one. So right here's another intro site cell, right? And I told you that we could also use these tight junctions between here like this to move drugs through. But the key point is they all require very specific needs, right? If it's a small drug that's hydrophobic, it could use this, right? If it's a large drug that's hydrophilic, it could use this. If it's a large drug that requires a receptor, it could use endocytosis and exocytosis. Well, there's another type of drug, and let me just kind of make this membrane for this intro site kind of make sense here. Oh my goodness. Let me get it to make sense here, right? There's another type of drug, which is a large drug, as I stated here. And this one is a type of drug that moves from a low to high concentration, which is kind of odd, right? H-I-G, yes, okay. High concentration, right? So that means we have a lot of it over here, right? That's not passive diffusion. This is facilitated diffusion, and we have low concentrations here, right, of that drug. And I'll just draw the drug there, the pill there, right? So this one moves from a low to a high concentration. And we're not worried about polarity. We're not worried about hydrophilic or hydrophobic properties. This type of one, because of the way the concentration moves, it requires this unique ATP transporter, right? And what this transporter does is when a drug, I'm going to draw the drug to look like it's a fraction, right? And it binds into this section here. When a drug binds and ATP is also delivered to its binding site right there, well then that drug binding to this transporter, this facilitated movement, right? This ATP active transport, this is actively transporting the drug. And I'll put here, this is an ATP dependent active transport. What's going to happen is once this drug binds into this pocket here, and ATP binds, this transporter, it's circular. It's going to essentially twist, right? Think about those machines you went to when you were a kid and you put a quarter inside and you twisted it to get a gumball. Well, that's what's going to happen with this. Once the drug binds and ATP is present, this whole machine here is going to twist. And what's going to happen is now that drug will be on this side because it just twisted, right? It just moved because of the ATP. And now that drug can be released over here with the higher concentration, right? So this would be ATP-dependent active transport. This would be another type of way these intro sites can move these drugs. So that is all I have for you right now. That's quite a bit, and then you are pretty much caught up with us on where we ended. So I will see you next week. I hope this helps, and if you have any questions on anything, just email me and I can clarify it. So good luck and happy studying.